Tengo el honor de presidir SLAGO, el Simposio Latinoamericano de Gastroenterología Oncológica. Por supuesto que contaremos con los mejores exponentes de la oncología gastroenterológica en nuestra región en Latinoamérica. Los esperamos a compartir esta reunión. Muchas gracias. Buenas tardes, vamos a dar inicio al módulo de tumores neuroendocrinos en este SLAGO 2021. En primer lugar, tengo el honor de presentarles a la doctora Raquel Riechelmann. Mi amiga Raquel es jefe del Departamento de Oncología Clínica del AC Camargo. Previamente ella se desempeñó como profesor adjunto en el Instituto del Cáncer del Estado de San Pablo. Es actualmente la directora científica del grupo de tumores gastrointestinales en Brasil y actualmente forma parte del Advisory Board de la Sociedad Europea de Tumores Neuroendocrinos. Raquel tiene una amplia experiencia en este campo con múltiples publicaciones a nivel nacional e internacional. Tiene actividad en investigación clínica y es una de las líderes y gran impulsora de trabajos cooperativos en nuestra región, en Latinoamérica. Raquel nos va a hablar hoy sobre aspectos nuevos en relación a los análogos de somatostatina, el uso de la terapia con radionúcleos. Raquel, muchas gracias.
Hello, I'm Dr. Riechelmann, and I'll be talking about new data on the use of somatostatin analogs and PRRT in neuroendocrine tumors, what is new since the ENET 2021. So these are my potential conflict of interest related to this topic. And we'll be discussing here three main aspects: the maintenance treatment with somatostatin analogs, the increasing of the dose of somatostatin analogs with the aim of tumor control, and how we can use peptide receptor radionuclide therapy, the PRRT, in the neoadjuvant setting with the aim to convert irresectable tumors to surgery. So let's start with the somatostatin analogs new data. So this is a very important study that was presented this year at the ENET 2021 with the use of lanreotide as a maintenance therapy after first-line treatment in patients with well-differentiated pancreatic NET who have non-resectable tumors. So the maintenance therapy with somatostatin analogs has been used by many clinicians, but since this study, there has been no robust data. So this was the REMINET study conducted by the French group, where they randomized about 50-something patients with pancreatic NET, G1 or G2. So the cutoff of the Ki-67 was 20%. All patients had a resectable tumor, either metastatic or locally advanced. And patients who had received first-line treatment, mostly with chemotherapy or targeted therapy, so not PRRT first-line, after 2 to 6 months, could be randomized to lanreotide or placebo. And the primary endpoint was the rate of progression-free survival at 6 months since the start of the maintenance therapy. And the study was presented here with a median follow-up of 27 months, which is, I assume, is a good follow-up time point. This is the patient characteristics. We can see that both groups were well balanced in terms of the main characteristics. The median Ki-67 was 5 between the two groups. Most patients received first line, more than 95%. And this treatment was mostly chemotherapy with an alkylating agent. So we can see temozolomide-based therapy, streptozotocin, or dacarbazine. And curiously, most patients had responded to first-line treatment here. So here, 75 and 85%. So a highly selected group of patients who responded to first-line chemotherapy. We don't see a 75 or 85% response rate with chemotherapy. So this really reflects a selection of patients who were good responders to chemo. And this is the progression-free survival. So a median of 19.4 for lanreotide, 7.6 for the placebo, with a hazard ratio of 2.46 favoring the use of lanreotide as a maintenance. The overall survival was trending for lanreotide, although this was not, is pretty much immature due to a low number of events. In terms of safety, most patients experience G1 or G2 adverse events. About 27% experience a grade 3, not necessarily related to lanreotide. The duration of the disease control, so among those patients who did not experience upfront progression, was pretty much long in the lanreotide arm, so 46.8% a month, versus 28.1 months for the placebo. So very important study suggesting that maintenance could be a good strategy for selected patients. The next study was the Clarinet 40 that was presented by Professor Pavel. So here, the Clarinet 40 was already presented at ESMO 2020, but at INES they presented the data on the quality of life. So the Clarinet 40 asked the question of, is it worth to increase the lanreotide? We have data on dose escalation with octreotide, but not since then with lanreotide. So here they tested in a phase 2 trial with 2 different cohorts. So it's not a randomized trial, but actually 2 different phase 2 trials within one, where they tested lanreotide 120 every 14 days. So instead of increasing the whole dose at once, it is given in a shorter interval, instead of every month, every 2 weeks. So patients had to have metastatic disease, pancreatic or mid-gut tumors, and positive expression of the somatostatin receptor, either with an octreoscan or a gallium-68. Patients had to have progression defined by RECIST 1.0, but within 24 months prior to enrollment. So a pretty long interval favoring a more indolent type of tumors. The Ki-67 cutoff was up to 20%, so only G1 and G2 tumors. So here are the characteristics of the 2 cohorts. So we can see that among the pancreatic NET group, there was a longer time from diagnosis to study entry compared to the mid-gut cohort, and the duration of the lanreotide prior exposure also was longer. Most patients with pancreatic NET had a G2 tumor, 75%, and the proportion was more even in the mid-gut tumor between G1 and G2. 40% approximately in both groups presented heterogeneous somatostatin receptor positive test, which means they were not homogeneously positive. And when we look at those who actually had an octreoscan, most of them had a grade 3 or 4 Krenning scale, so highly positive octreoscan. In terms of the proliferative index, the Ki-67, most patients, 54% in the pancreatic NET group, had a Ki-67 between 5 and 10, but only 20% in the mid-gut tumor had a higher Ki-67. Most of the patients had actually Ki-67 of less than 2%. And this is the results. So we see here a median progression-free survival 8.3 months for the mid-gut cohort versus 5.6 in the pancreatic cohort. When we looked at the stratification by the Ki-67, those with a Ki-67 of less than 10% experienced a median PFS of 8 months in both groups, but actually the PFS was quite low when the Ki-67 was higher than 10%. So only 2.8 months for pancreatic NETs versus 5.5 months for the mid-gut group. When we look at the duration of stable disease and control, excluding those who experience upfront progression, this was longer in the mid-gut NET group versus the pancreatic NET. And we can see here also in the rate of progression-free among between the 2 groups according to the time of the evaluation at week 24 and at week 48. In terms of safety, adverse events was experienced by most patients, but serious adverse events was experienced by 10% of the pancreatic group and 25% of the mid-gut NET, which seems quite high. In terms of quality of life, so this was the new data presented at ENETS. There was no deterioration of quality of life throughout the study, although we had this significant proportion of patients who experienced significant serious adverse events, and we can discuss this later. But when we look at the two different instruments that were used, the KLK C30 and the 5D-L5, looking at the quality of life throughout the study, we see that the confidence intervals, they cross the unity, so not significant difference from the baseline. And now we have data that increasing the dose of lanreotide is able to control the disease for some patients, especially those with a low Ki-67. But do we have this data for octreotide? And the answer is yes. We have the data one trial that randomized patients to receive either octreotide's LAR 60 milligrams per month versus the lutetium 177 plus octreotide. And these patients had progression on prior octreotide. So when the dose increased arm with the 60 milligrams of the octreotide, we have a PFS median here of approximately 8.5 months. So very similar to what we see with lanreotide, asking a similar question. Now moving to what we have new for PRRT in this setting. So I bring here this interesting study was presented as a poster at ENETS. It was a joint analysis of several phase 2 trials of PRRT with lutetium, looking at how this treatment strategy works for patients with functioning tumors. So they pulled together 68 patients, 88% of them with a clinically important hormonal-related syndrome. And what we see here is that the PFS, if we put the curve here on a 50%, we see at least 2 years of progression-free survival, with the overall survival reaching a plateau, so probably a few events to actually estimate a proper survival. But what we see also here is that the overall survival is longer for patients who achieve a response to the syndrome. So it seems that patients with functioning tumors also experience a good control of disease, and we assume of the hormonal-related syndromes with PRRT. And lastly, an important question that also comes in tumor boards, and I'm pretty sure among all of you who are watching this presentation now, is what we can do to convert patients with locally advanced disease to a surgery. So what we have in terms of treatment strategies in it, leading to response rate that could lead to surgery. We have the somatostatin analogs offering very low rates of response, also the targeted therapy with everolimus and sunitinib, but we have higher response rates with lutetium and chemotherapy, as an example with CAPTEM. So what we have for lutetium. So this is actually was a whole session on ENETS this year. Not many new data, but this probably is one of the most important. It was presented, published in 2017, but actually looked at experience in a single center study, comparing patients who actually had a PRRT followed by surgery versus those with an upfront resection, and trying to match these patients as resectable, borderline resectable. And what we see in terms of disease-free survival is that those patients who actually had a neoadjuvant treatment and went for surgery and achieved an R0 resection had a longer disease-free interval. So suggesting that for selected patients, if we can decrease the tumor burden and lead them to surgery, we're probably going to have an impact on their course of disease. So to summarize as a conclusion, what we have now is that maintenance therapy with somatostatin analogs, and here we have the REMINET study with lanreotide, improved progression-free survival in G1 and G2 pancreatic NETs. But remember that 75% treated with first-line chemotherapy and approximately 75 to 85% responding to first-line treatment. So very selected patients with good responsive tumors. Increasing the dose of somatostatin analogs, we this clarinet 40 using lanreotide 120 every 2 weeks. And we have the control arm of the NETTER-1 trial using octreotide 60 milligrams. So this strategy for progressing somatostatin receptor positive GAPNet
aquellos pacientes que tenían receptor de somatostatina positivo
for those patients with a low Ki67. So it could be a strategy of a low toxic agent in that setting. PRRT seems to be very effective for NET-related hormonal syndrome tumors. We have the PFS based on tumor control, but we assume the treatment for the syndrome is also effective as well. And PRRT as a strategy to convert unresectable to resectable NET, it's likely to occur in a few cases, so I think that should be also an option that could be discussed in tumor boards. Thank you.
Muchas gracias.
Continuando con el módulo de tumores neuroendocrinos, vamos a presentar ahora a la doctora Marianne Pavel. Es un gran honor para mí presentar a Marianne. Ella es Senior Physician y jefe de endocrinología en Friedrich Alexander University en Erlangen, Alemania. Es médica certificada en medicina interna, endocrinología y diabetes durante los años 2000 y 2001. A su vez, ha desempeñado actividades como directora asistente en la Universidad de Charité, donde además fue designada como profesora en el campo y en el área de tumores neuroendocrinos. Bajo su conducción, Charité fue designada como uno de los primeros centros de excelencia en esta patología dependiente de la Sociedad de Tumores Neuroendocrinos Europea en INET, y por otra parte actualmente se desempeña como chair de la Sociedad Europea de Tumores Neuroendocrinos. Tiene gran número de publicaciones, ha formado parte de muchos de los estudios pivotales en los últimos 10 años en el área de tumores neuroendocrinos. Será un honor poder escuchar su presentación. Ella nos va a hablar hoy de inhibidores de tirosinquinasa, el uso de radionúclidos en tumores neuroendocrinos y aspectos relacionados con el tratamiento actual. Marianne, muchas gracias.
Thank you, Juan.
Muchas gracias, Juan.
Big pleasure for us.
Dear colleagues, it's my great pleasure to participate in this
Colegas, es un
symposium,
placer participar
although
en
I
este
definitely
simposio,
prefer a real meeting.
preferiría
My
que
topic is
fuera
new
una reunión
developments for
presencial.
therapy of neuroendocrine
Voy a hablar de
neoplasm.
nuevos desarrollos para terapia de las neoplasias neuroendocrinas.
This is to show you the evolution of
Esto es para
systemic therapies.
mostrarles la
We have
evolución
several
de las terapias
treatments
sistémicas
available for syndrome control or
que han estado
antiproliferative
disponibles
therapy
para
that you
control
can
del
see on the
síndrome
top of the
o terapia
graph
antiproliferativa.
that
Como
are
podemos ver
approved or
arriba,
available. And
hay distintas
there are other
alternativas
drugs under
disponibles
exploration
y hay otras
more
bajo
recently, and that
exploración.
includes
Esto
anti-angiogenic
incluye
drugs, tyrosine kinase
medicamentos
inhibitors, and
antiangiogénicos, inhibidores de
immunotherapy, as well as
tirosinquinasa
other novel compounds.
y otros nuevos compuestos.
The management of NET is very complex
El
because the
manejo
disease is very
de estas
heterogeneous.
neoplasias
We
es
have different treatment
complejo.
goals, syndrome control,
Hay
tumor growth control,
distintos
or
metas de
both.
tratamiento,
And
control
several
de
treatments are
síndrome,
available,
control de la
and
patología
our
y
treatment is
distintos
very much
tratamientos
based
disponibles.
on the assessment of different disease
Y esto se
phases.
basa
This includes
en
the
la
functional
evaluación de las distintas
activity,
etapas.
histology, and other features of
El
the disease,
tratamiento
including
depende
somatostatin receptor stages.
de la tapificación y de la histología.
Why do we need novel therapies? So
¿Por qué
still we have a
necesitamos nuevas
limited number of
terapias?
therapy options available. Some
Hay
patients do
pocos
primarily
números
not
de
respond
terapias
to some of the
disponibles.
treatments,
Algunos
or others may
pacientes van a tener
develop
resistencia
secondary
primaria o
resistance.
secundaria.
So we need novel therapies in
Y
patients who
necesitamos
fail
nuevas
to
terapias
available
en
standard
pacientes
therapies.
que han fallado con las
Furthermore,
terapias
we
estándar.
still have low to moderate objective response rates, particularly with
Aún
targeted drugs.
tenemos tasa de
And we need
respuesta
some novel
objetivas bajas
compounds
moderadas.
to downstage the
Y
disease in
necesitamos
some
estos
instances,
compuestos nuevos
or we still
para
expect
hacer
by
terapias
achieving
combinadas.
higher response rates, this may translate to a more durable benefit or even increase of overall survival, although that has
Nuevas
never
terapias
been
pueden
shown so
llevar
far. But for
a
several
una
purpose,
prolongación de la
combination
sobrevida.
therapies are also explored in that respect. We have to keep in mind
Hay que tener
that
en
we do
mente
not cure our patients with all the available treatments so far.
que si no,
So novel therapies target multiple or
las
key
nuevas
pathways
terapias
and may improve the outcome
pueden
of
mejorar
our
los
patients or
resultados
offer new
de
options
nuestros
where the standard
pacientes.
is exploited. So how can we improve outcomes? This
¿Cómo
can be either
podemos
by
mejorar
combination
los
therapies,
resultados?
also by
Esto lo podemos
finding
hacer
the
a través de
accurate
terapias
sequential therapies
combinadas,
for the individual patients, and this may
también
differ
terapias secuenciales
from by
precisas,
primary site or other conditions. Maintenance therapy is also
las
something
terapias de
upcoming,
mantención,
as has been shown in the Reminet study, short in
como fue
exposure to
mostrado
more
en el
aggressive
estudio
treatments like
Reminet.
chemotherapy, and move on with a somatostatin analog, for
Se puede usar
example, to
análogos de
prevent
somatostatina
progression
luego de la
instead of
quimioterapia.
waiting for a progression. So that is another approach of improving
Este
outcomes.
es
Then we have, of
otro
course, novel
abordaje para
drugs to
mejorar
consider,
los
and I will
resultados.
discuss this more in detail. But just want to stress
Vamos a
that
discutir esto en
also
más
a lot of
detalle.
molecular sequencing studies are ongoing, not only looking into
Se están
genetic
llevando a cabo
alterations, because we know that
nuevos
these are rather
estudios
rare, particularly in the intestinal
de
nets, small
terapias
intestinal
guiadas
nets,
molecularmente.
but also in more comprehensive molecular analysis, including epigenetics, may be helpful to stratify patients for future treatments. But
incluyendo
that is not ready
epigenética
to
para
enter the
aquellos
clinics right
pacientes
now.
que tienen el tratamiento.
So there are a lot of novel drugs in the field that are
Hay una
currently
serie de drogas
explored, and
novedosas en
they
el campo de
cover
los tumores
hallmarks of cancer
neuroendocrinos.
that we did not address so far by compounds that
Hay
are
varios a los cuales
currently
que no nos hemos
used.
referido
And this includes all the drugs highlighted here.
en pantalla, ven
And
todas las
I
drogas
highlighted
destacadas aquí,
particularly TKIs and immunotherapy because
particularmente
these classes
los
of drugs
inhibidores
advanced most in
TKI
this field. And this
y
is what I would like to discuss more in
K4,
detail.
6
Next to it,
inhibidores
novel radiopeptides are an exciting
y
field,
algunos
also novel
péptidos
emitters,
novedosos
and this is I will address at the end of my talk.
y los nuevos radiopéptidos PRRT, a los cuales
What
me
is the
referiré al
current
final de
status
la
of the use
charla.
of tyrosine kinase inhibitors? Sunitinib was the only approved drug
En relación a
and
los inhibidores de la
pancreatic
tirosinquinasa, el
exclusively as a
sunitinib es el
TKI
primero
for a
aprobado
long
para el
time.
NET pancreático.
Several trials were ongoing also to explore
Varios
other
estudios que están
TKIs, and that
sucediendo
included
ahora
pazopanib,
para
axitinib,
analizar,
in part with
incluyen el
only modest
pazopanib
results, and
y
one
otros
TKI
TKI
is
como el
axitinib that
axitinib
moved from phase 2 to 3,
que se han
and
desplazado a estudios
surufatinib
fase 2
has
a fase
recently been
3
approved in China,
y el
not only for
surufatinib que
pancreatic
se
NET, but
aprobó en
extrapancreatic NET.
China, no para el NET pancreático,
And
sino
of
más bien
course,
para
there
el
is a need for new
extrapancreático.
anti-angiogenic drugs, new TKIs, because there may be
Tenemos
primary
también nuevos
resistance, or
TKI,
patients
drogas
may develop
antiangiogénicas
secondary
que pueden estar
resistance
siendo
to TKIs
desarrolladas
used
como tratamientos de
in
segunda
first or
línea
second line setting or later on.
o
So
posterior.
here you can see an overview of the more recently
Aquí
explored
podemos ver una
TKIs,
revisión
and you can see that the mechanism of action differs, not only targeting VEGF receptors, but in part FGF receptors, and also MET inhibitor is a compound that is addressed by cabozantinib. And so these drugs can be also used in a sequential way when somebody is refractory to one of the TKIs. But we are just at the beginning of really bringing these drugs to the clinics. And they have first been studied in phase 2, and some of these compounds that are highlighted here, except for lenvatinib, moved to phase 3. And the axitinib trial, axitinib trial, is a phase 2/3 trial. Results of that study have been recently shown at ASCO GI. This was a study designed for non-pancreatic NET to really explore what is the value of axitinib in that setting. Patients were enrolled with progressive disease. Up to 2 prior treatment lines were allowed. No anti-angiogenic drugs. And this was a placebo-controlled trial, but both lines of treatments kept octreotide LAR as a standard treatment. And you can see here that the primary endpoint, PFS, was not reached. This result was not significant, although the PFS was longer with axitinib compared to placebo. The central reading is still pending, and a better understanding of subgroups of patients by primary site, for example, who may have a preferential benefit here. Looking at the objective response rates of that trial, you can see that axitinib in combination with octreotide LAR significantly improved the objective response rate as compared to octreotide and placebo. And you can also see a higher proportion of patients developing tumor shrinkage as compared to octreotide plus placebo. This is just to show you the design of 3 phase 3 trials. The SUNNET-EP and PNET study, one was just designed for pancreatic NET and the other one for extrapancreatic NET. It was placebo-controlled. The patients were allowed not to have more than 2 prior systemic treatments and were enrolled while being progressive within a time frame of 12 months. This is a study result in the extrapancreatic NET setting. You can see here a benefit with respect to prolongation of progression-free survival. In contrast to the axitinib study, you also see that this is a more aggressive patient profile. The PFS on the placebo arm was rather short, less than 4 months. And it is of note that here primarily rectal carcinoids have been included, and also lung NET that have a worse prognosis in contrast to, for example, small intestinal neuroendocrine tumors. Also, the objective response rate was higher with surufatinib in contrast to placebo. In the pancreatic NET study, there was also a benefit with prolongation of progression-free survival, and also the objective response rate was significantly higher. So based on these results, surufatinib was approved in China for pancreatic NET and extrapancreatic NET. Cabozantinib is a compound that has been studied in phase 2 with very promising results. It is targeting also the MET pathway. The response rates are outlined here for 2 subgroups, carcinoid and pancreatic NET, and a high proportion of patients had disease control with this compound, and you can see a very durable response in this small phase 2 study. This study paved the way to a phase 3 study that is currently ongoing. This is a placebo-controlled study that is very large and enrolling pancreatic and non-pancreatic NET with progressive disease within 12 months. At least they must have undergone 1 prior FDA-approved systemic treatment, and also SSA therapy was allowed. The primary endpoint is progression-free survival. The results are pending, and this may enlarge the portfolio of TKIs that may be available for the management of NET in the future. This is just to share with you one ongoing study in Germany. There are other studies ongoing also in combination therapy, I will mention later on. But it's just to give you a glimpse on what is ongoing in the field in NENG3. These are the more aggressive neuroendocrine neoplasm. It's a higher Ki67, and this should give us more insight on how this compound may be active in more aggressive NET patients. It's a very small phase 2 study. The results of lenvatinib in neuroendocrine neoplasms in GI and pancreatic NET had been shown at ESMO 2 years ago, and also at ASCO in 2019. These results are very striking in that respect, that a high objective response rate was achieved in pancreatic NET, and this was around 40%, and in GI NET 20%. That is higher in comparison to what had been reported before with sunitinib, and the PFS was also quite promising. However, this study did not move to phase 3. So if you look at the TKIs available, they will play an emerging role. We have sunitinib approved for pancreatic NET, surufatinib so far only approved in China, but more trials are under construction to make that drug more available outside of China. And you see some other results summarized here. What we can draw as a conclusion, the results are not yet practice changing except for surufatinib in China, first TKI approved in extrapancreatic NET globally, and a second TKI approved in pancreatic NET next to sunitinib. There may be off-label consideration in some individual patients where you exploited all the treatment options depending on reimbursement issues and access to these compounds. The cabinet study results are pending, but they may impact the treatment algorithm in the future. I would like to move to immunotherapy in NEN. You can see here a large number of trials that have been performed with different PD-1 and PD-L1 inhibitors, also with CTLA-4 inhibitors as mono or combination therapies, in part also in combination with other anti-angiogenic drugs. I would like to shortly summarize the results. Objective response rates are low in pancreatic NET and non-pancreatic NET in patients that had been enrolled in these trials based on PDL positivity or where it didn't matter. There was not a difference. There had been also responders being reported, all being PDL1 negative, as in the Keynote 158. The spotalizumab study has been reported before and published this year in endocrine-related cancer. PDL1 expression was not required. You can see low to modest response rate. The highest response rate was observed with lung neuroendocrineoplasm. However, the overall trial goal to achieve in the overall cohort 10% objective response rate was not achieved. So that also did not move to a phase 3. We need to better understand how the response is in subsets of patients based on biomarkers, of course. Here you can see a summary of the results of prospective phase 2 studies that included NENG3, and you can see that the objective response rate is mostly less than 5% or less than 7% with avelumab. So there was much hope, but low outcome. In many studies also the response was not very durable. So that the future is combination therapy, and this may be more than inhibition of PD-1 or PD-L1. There may be different combination therapies, with several other compounds, radiotherapy, targeted therapy, also combination of several immune targeting compounds, or totally different approaches like vaccination, CAR T-cell therapy. So that's a very exciting field that is poorly understood in NEN. So the attempts to enhance effects of immunotherapy that have been done so far or are underway is the use of dual checkpoint inhibitors. I will show you the results that have been achieved so far. And there are trials ongoing with combination therapies. This includes PRRT, TKI, and PARP inhibitors. And the aim is with some of these approaches to convert an immunologically cold tumor into a hot tumor, or to turn it into the microenvironment into an inflammatory state. And the high-end use of immunotherapy would be bispecific T-cell engagers. There's also studies under consideration, and CAR T-cell therapy is in a preclinical field, but it may be very promising in the future. So to wrap up with results that we have so far, showing you the DART study that first reported a high objective response rate in the poorly differentiated NEC. You can see it's a small number of patients that had been included here. These are the red bars with high-grade tumors, around 40% objective response rate, but no response in the well-differentiated NET. This was a small study, and if you can see here the results with nivolumab and ipilimumab in another study from Australia. It's also a small study. You can see again that the responses that are seen that amount to 24% in that study, but here you can see lumped together high-grade and the low-grade tumors. The high-grade tumors are marked with a red dot here, and you can see intermediate-grade tumors. All responders had either high-grade tumors or intermediate-grade tumors, but no low-grade tumors showed really objective responses here. And this is a DUNE trial from the Spanish group for neuroendocrine tumors. And it's another selection of checkpoint inhibitors. You can see here the clinical benefit rate that does not only include partial remission, but also stabilization of the disease. This is shaded in a light blue here. The proportion of patients declared as being responders, including stabilization of disease, is rather low. And the non-responders are marked in red here. And still some have not been finally analyzed. So these are preliminary results. What you can see here on the right hand is the outcome in NENG3. Here the endpoint was overall survival, what is appropriate for poorly differentiated neuroendocrine tumors. Some few NETG3 patients had already also been included. You can see the overall survival at 9 months is only 36%. And the objective response rate in that study was rather low, less than 10%, in contrast to the 44% that had been reported with the DART study. So there are some controversial results. We need to better understand which subsets of patients respond. There are several criteria we could look at. So far, it does not seem to be the PD-L1 expression. It can be the tumor mutational burden and other aspects that are also considered in other tumor entities. What I would like to show you here is the tumor mutational burden. These are results from the Keynote 158. And you can see here highlighted for the NET cohort that patients that have high tumor mutational burden had a higher objective response rate in contrast to those with not a high tumor mutational burden. But overall, you can also see that only a minority of the patients had a high tumor mutational burden, only 5 out of 85 patients that were lumped together here. So if that is present, that may drive your selection towards immunotherapy. But again, it's a rare event in NEN. Interesting results have been reported at ASCO GI last year already on the combination use of atezolizumab plus bevacizumab. You can see here higher objective response rate for well-differentiated neuroendocrine tumors, 15 to 20%, but 20% in the pancreatic net, and these are the exopancreatic net. And what is also interesting is a rather durable benefit in these two cohorts, 15 to 19, more than 19 months, depending on the cohort. And also the 1 year progression-free survival rate looked very promising, particularly in the pancreatic net. So we need to better understand what is the best combination for several subsets of patients for the use of immunotherapy. Preliminary results of temozolomide and nivolumab are also available. You see it's a small number of patients, but the disease control rate was very high. The objective response rate was 25%, and you can see all responders had been foregut tumors and higher proliferating tumors. It's hard to understand so far what is the add-on value in comparison to the use of temozolomide alone. So we need to wait for the final results of that study and more studies in that respect of combination of chemotherapy with immunotherapy. To conclude so far is that immunotherapy is not ready to use in NEN outside of clinical trials. There's limited activity with single checkpoint inhibitors. Combination therapies look more promising. There are some ongoing studies that you can find on clinicaltrials.gov. It's a Spanish trial combining the standard chemotherapy of carboplatin etoposide upfront as a first line with nivolumab as the first trial of that kind. There's also a French multicenter trial ongoing that looks into the combination of nivolumab plus ipilimumab versus nivolumab monotherapy in gap neck and large cell lung neck. And in Spain is a multi-cohort study ongoing combining atezolizumab and cabozantinib, and there will be head and neck cohorts included. And in Germany, there's another study short before initiation looking into cabozantinib plus avelumab in NET-G3 and neck cohort only with low Ki67, the neck cohort. So there's many interesting approaches, and we need to better understand the best approach. Finally, I would like to address advancements in the field of PRRT. So with the NET-1 study, PRRT has become a standard treatment in advanced midgut and pancreatic NET, a second line rather in midgut NET. In pancreatic, the line is less clear. Studies are ongoing there, like the COMPETE study that should address the line in pancreatic NET. But this field is really exciting and rapidly evolving with new radiopeptides. This includes somatostatin receptor antagonists, also novel peptides, and combination therapies. Phase 1-2 trials are ongoing with PARP inhibitors, with immunotherapy and PRRT, or also with immunotherapy and liver-directed therapy versus PRRT. And also combination trials with chemotherapy are ongoing. It is a very exciting field to look into the radionuclides that are alpha emitters, for example. And the advancements also include the exploration in a first-line setting. And here the NET-2 study is ongoing, recruiting patients with NET-G3 or NET-G2 that have unfavorable profile, for example, very advanced disease, Ki67 more than 10%, so that it's justified to offer first-line PRRT treatment that has not been explored so far in a prospective way. Looking into the results of somatostatin receptor antagonists, there is a compound that has several names that are outlined here that can be used synonymously. It's a small study with 20 patients, a first of its kind, one of the first ones, showing a very good response rate, 45%. That is very striking. However, that study faced some toxicity that was quite high, also particularly hematological toxicity, more than 50%, grade 3-4 after cycle 2. But after dose reduction of cycle 2, this grade 3-4 toxicity, hematological toxicity resolved. So that was a dose-finding study. And so this may pave other studies to better understand what is the value of somatostatin receptor antagonists. This is still a promising compound. However, alpha emitters have shown so far very striking results. They have higher linear energy transfer, causing double-strand DNA damage. And this is a first-in-human study. And this has been used after lutetium dotatate has been used. And there's the results there from 24 patients only after 2 cycles. And there had been 2 groups, those being progressive on PRRT, on the standard PRRT, or being stable. And you can see the objective response rate is quite high, nearly 60% or more than 60%. And also the CGA decrease is quite remarkable, with more than 50% decrease happening in more than 50% of the patients. There was also another study from Germany that was very small, first of its kind, already reported in 2014 with 7 patients, also showing objective response rate of more than 80%, 1 complete responder included. However, at that time, also 1 MDS AML had been reported. At NANETS last year, results of a phase 1 had been reported with 16 patients across 4 cycles, and results of 6 patients have been reported, also 5 of 6 responding, amounting to more than 80% objective response rate, including 4 patients with complete response. No clinically significant drug-related toxicity had been reported up to 18 months after treatment, and also quality of life had been improved. This was the same with the other study that I just had shared with you. So in summary, we have new developments that focus on evaluation of TKIs, on immunotherapy and PRRT. TKIs are evolving in the field in NET-G1, G2. Surufatinib is the first TKI to demonstrate efficacy in exopancreatic NET in a phase 3 placebo-controlled study. Axitinib was not associated with increased PFS, but with improved objective response rate. We have to wait for further subgroup analysis to understand which subsets of patients nevertheless may benefit from axitinib, although the primary endpoint was not met. And we need to wait for the results of the cabozantinib study in phase 3 for exopancreatic and pancreatic NET. Immunotherapy results were disappointing with the monotherapy, having low or absent objective response rates. Dual checkpoint inhibitors were more promising, particularly in the neck. However, the data are not consistent from several trials. Some combination trials are still ongoing with dual checkpoint inhibitors. I shared with you the NIPINEC study from France. And other combinations of checkpoint inhibitors with anti-angiogenic drugs are very promising. We, of course, need biomarker analysis that are still pending from the studies that I shared with you. And we need more trials to better understand the role of immunotherapy in this field. Novel compounds with PRRT are under development. This includes somatostatin receptor antagonists and alpha emitters with remarkable results, and also some promising combinations like PRRT with checkpoint inhibitors. Thank you very much for your attention. The talk is now open for discussion.
Hola, buenas tardes. Mi nombre es Manuel O'Connor. Soy médico oncólogo en el Instituto Alexander Fleming y desde ya agradezco la invitación para participar en este SLAGO 2021 virtual. Vamos a hablar de un tema interesante en el área de los tumores neuroendocrinos que tiene que ver con los tumores de tipo G3 o de alto grado. A modo de introducción, tenemos que tener en cuenta que la morfología, más allá de la tasa de proliferación y el grado de diferenciación, tumores bien diferenciados o poco diferenciados, constituyen una población en sí bastante heterogénea. Aquí vamos a hablar de los tumores G3, incluyendo los tumores bien diferenciados y los carcinomas neuroendocrinos, que como mencionábamos, es un grupo heterogéneo y en el cual el pronóstico va a estar dado no solo por el índice proliferativo, sino también por la localización del tumor primario. La primera pregunta que nos hacemos es si todas las neoplasias neuroendocrinas G3 son la misma enfermedad. Fíjense que este es el abordaje desde el punto de vista actual, cuando hablamos de la clasificación, donde tenemos tumores bien diferenciados, donde están los clásicos G1 y G2, con Ki67 menor al 20%. Identificamos el grupo de peor pronóstico o de alto grado, los carcinomas neuroendocrinos, habitualmente con un índice proliferativo mayor al 20 o en realidad al 55%, de acuerdo a la clasificación actual. En medio de esto tenemos los tumores de tipo G3, que son tumores bien diferenciados, pero por definición de grado 3. Entonces, desde un punto de vista pragmático, uno debería interpretar o tratar de definir este grupo que está exactamente en la parte media entre los tumores bien diferenciados, fíjense, G1 y G2, y 67 habitualmente menor al 20%, y los carcinomas neuroendocrinos que tienen habitualmente Ki67 por encima del 50% y constituyen el grupo de peor pronóstico. En un estudio de tipo observacional en el registro en Estados Unidos, con un análisis en más de 160.000 pacientes, evaluando las características de pacientes con carcinoma neuroendocrino de origen pulmonar y extrapulmonar, van a ver que la mayor parte de los casos son de origen broncopulmonar. Prácticamente menos del 10% corresponden a los de origen extrapulmonar, siendo los de origen gastrointestinal o los tumores de primario desconocido las subtipos o localizaciones más frecuentes. ¿Cuál es la diferencia cuando hablamos entre células grandes y células pequeñas? Acá ustedes pueden ver, por ejemplo, en los primarios desconocidos o en otros sitios, habitualmente con predominio de small cell. En los de origen gastrointestinal, que es el punto en cuestión de la charla, van a ver que hay un porcentaje aún mayor de células grandes y no solo de células pequeñas. Esa es la importancia de interpretar adecuadamente, más allá del subtipo celular, aquellos pacientes con carcinomas neuroendocrinos. Acá cuando analizamos los carcinomas neuroendocrinos poco diferenciados, en el cual un subgrupo hasta un 50 o 60% pueden constituir el origen o tumores pancreáticos, están dentro de esta clasificación que ustedes ven aquí, por ejemplo, dentro de los de origen colorectal, un 24%, o páncreas, dentro de las localizaciones más frecuentes que constituyen prácticamente también un 20%. A su vez, lo que mencionábamos al principio, la localización del tumor primario tiene distintas implicancias. Fíjense cuando uno analiza lo de origen gastrointestinal, las formas de presentación entre enfermedad localizada, regional o con enfermedad avanzada, el pronóstico de sobrevida varía en función a las distintas localizaciones. Por ejemplo, pueden ver ustedes aquí los tumores de origen de intestino delgado, con características de tumores poco diferenciados, tienen mejor sobrevida que los de origen pancreático, por ejemplo, o los de origen esofágico. Por eso mencionábamos que la localización es un punto a tener en cuenta en esta situación. ¿Qué sabemos en cuanto a la estratificación de las neoplasias neuroendocrinas G3? Bueno, en el espectro biológico de la enfermedad, y remarcando la heterogeneidad de este tipo de tumores, vamos a ver lo que mencionábamos al principio. Este sector intermedio de los tumores con Ki67 entre 21 y 55%, tenemos que tratar de definirlos si tienen características de tumores poco diferenciados de alta agresividad, donde el estudio funcional de elección es la fluorodeoxiglucosa y los esquemas en base a platinio y toposio son el esquema estándar, o si tienen características similares a los G2, en los cuales puede haber un estudio dual y expresión de receptores somatostatina con positividad en el galio o en el octoscan y con tratamientos que pueden ser similares en algunos casos a los tumores neuroendocrinos de tipo G2. En base a un estudio multisociedades que se hizo en nuestro país en cuanto a recomendaciones para el diagnóstico y tratamiento, quiero destacar en este caso cuál fue el algoritmo que se planteó para los pacientes en base al estudio funcional. Fíjense, y esto extrapolado también de guías internacionales, aquellos pacientes con tumores bien diferenciados, G1 y G2, independientemente del sitio de localización, habitualmente con Ki67 menores al 20%, el estudio de elección es el estudio del PET con galio 68 como método de elección para estudio funcional. Los tumores neuroendocrinos G3, que habitualmente pueden tener un Ki67 entre 20 y 55% en los casos, es donde tratamos de definir, o sería una indicación para el denominado estudio dual, con estudio de fluorodeoxiglucosa y el PET con galio en los casos que tengamos o necesitemos definir mejor el pronóstico en este subgrupo. ¿Qué sabemos en cuanto al tratamiento en esta entidad o en este subgrupo dentro de los tumores neuroendocrinos? El problema con los tumores de alto grado, como bien está señalado en esta revisión por el doctor Hafdan Sorri y parte del grupo europeo, tiene que ver claramente con la heterogeneidad que los caracterizan. El Ki67 sabemos que es un factor pronóstico y predictivo. Fíjense, esta es la serie de 300 pacientes del grupo nórdico, en donde en aquellos pacientes con Ki más del 55% tienen mejores tasas de respuesta, pero sin embargo tienen una peor sobrevida asociada, ¿sí? Por eso decíamos que tiene un impacto pronóstico, pero también predictivo en los carcinomas neuroendocrinos. Este fue uno de los primeros datos que mostró el Ki67 en este escenario, también como un factor predictivo, como lo mencionábamos inicialmente. Algunas diferencias desde el punto de vista práctico entre los NET-G3 y los carcinomas tienen que ver con la respuesta a quimioterapia en base a platino, donde es claramente superior en el caso de los carcinomas, pero variable en el caso de los NET-G3. También es variable la sobrevida libre de progresión con los esquemas de quimioterapia, habitualmente claramente menor a 6 meses en los carcinomas neuroendocrinos, y fíjense aún en el estadio con enfermedad avanzada, también una variación importante con respecto a los datos de sobrevida global. Por eso decimos que este grupo de los NET-G3 es un grupo de interés para tratar de identificarlos y eventualmente ofrecer otras opciones terapéuticas. Cuando se analizan en distintas series las características y el tratamiento, fíjense lo que marcábamos previamente, tasa de respuesta objetiva, por ejemplo, 17 versus 35% para el caso de los carcinomas neuroendocrinos, tasa de control de enfermedad 68 versus 33%, y la mediana de sobrevida global, por ejemplo, no alcanzada, como ustedes pueden ver en la curva de sobrevida, en el grupo de los NET-G3, y sin embargo aquí sí identificamos sobrevidas medianas cercanas o apenas superiores al año en el caso de los carcinomas neuroendocrinos. Por supuesto que esto también tiene un impacto en base a las características de la estadificación inicial en estos pacientes. Segundas y terceras líneas tienen resultados muy pobres habitualmente. Acá simplemente para señalarles, si ustedes miran los distintos esquemas en relación al tumor primario, posibles tratamientos o regímenes de segunda línea y primera línea, van a ver que es bastante heterogéneos, esquemas en base a taxanos o irinotecan, digamos, tratamientos más salientes, o temozolomide, en algunos casos aún en progresión a los esquemas con platino, pero la mediana de sobrevida global, si ustedes miran, realmente bastante modesta en este escenario, y las medianas de sobrevida libre de progresión que no superan los 3 o 6 meses. Por eso sabemos que el escenario, más allá de una primera línea, fundamentalmente en el caso de los carcinomas neuroendocrinos, es bastante serio y es claramente un escenario en el que no tenemos buenas opciones terapéuticas luego de la progresión. El otro punto a tener en cuenta es la localización del tumor primario. ¿Por qué? Porque en casos de esófago o en unión esófago-gástrica, la quimioradioterapia puede tener un rol definido. No está tan claro el rol de la cirugía en este escenario y todavía se extrapola a lo que se utiliza en small cell de origen pulmonar. Acá tienen una serie donde se evalúa la cirugía justamente en aquellos pacientes con carcinoma neuroendocrino donde la radioquimioterapia puede tener un rol. Si hablamos de los de origen colorectal, acá hacemos la misma diferencia, en el cual el esquema de platino de topocio, si ustedes miran la tasa de respuesta, por ejemplo, cuando comparan con todos los pacientes, en el caso del colon, 16%, una tercera parte con estabilización de enfermedad, 60% de progresión inmediata, por lo cual también en nuestra experiencia, los resultados en este escenario son bastante pobres con el esquema clásico de platino y topocio, y utilizamos esquemas similares a los que hacemos en adenocarcinoma colorectal, como se señala también en esta experiencia. ¿Qué sabemos de esta patología hoy en día en la era de medicina de precisión? Bueno, fíjense, este es un estudio interesante donde se analizan el distinto perfil molecular en base a histología para correlacionarlo en los tumores de G3. Acá tienen la estratificación que hablábamos previamente y el posible enriquecimiento a través de distintos genes. Fíjense en NET-G3, bastante pobre, en los carcinomas, pero con Pi menor al 55%, algunas características de P53 o KRAS, pero claramente donde se enriquece la población con estas características moleculares de P53, Carras, mutación del BRAF, muy similar a lo que sucede en adenocarcinoma colorectal, es en el subgrupo con un Ki67 mayor al 55%. Inclusive, cuando uno analiza las curvas de sobrevida, mejores para los NET G3 y claramente diferencia los dos subgrupos en el escenario de carcinoma neuroendocrino con Ki67 menor o igual al 55%. Esto es para tratar de tipificarlos mejor desde el punto de vista molecular. Algunas mutaciones accionables pueden ser observadas en este subgrupo. Fíjense, mutación del BRAF B600E, como en cáncer colorectal, probablemente para terapia dirigida, o las fusiones en TRAC, menos del 1%, una frecuencia muy baja en esta patología. Inestabilidad microsatelital, probablemente en las neoplasias de alto grado, descritas hasta en un 4% de los casos, alteraciones de reparación del DNA, BRCA o ATM, o mutación de ATM, u otros genes asociados a la reparación homóloga que se han visto, por ejemplo, y descrito en la primera clasificación molecular en los neuroendocrinos pancreáticos. Es decir, que esta es la contrapartida en relación a posibles mutaciones accionables en este subgrupo de pacientes. La experiencia en Latinoamérica, el grupo nuestro, que mostramos la experiencia con 64 pacientes, todos con tumores neuroendocrinos G3, con una baja expresión del PDL1, 7,8%, y muy baja presentación de inestabilidad microsatelital, menos de lo que está reportado en la literatura. El subgrupo de pacientes, 77 pacientes del grupo de la doctora Riechelmann, en Brasil, mostrando ventajas en cuanto a sobrevida en los NET G3 no pancreáticos, y donde el grado de diferenciación mantiene la variable más importante en el análisis multivariable de esta serie de casos en el grupo de la doctora Riechelmann. Acá ellos encuentran TMB e inestabilidad microsatelital en un subgrupo, un porcentaje mayor al que encontrábamos aún en nuestra serie en Argentina, lo cual seguramente puede marcar algunas diferencias y también con respecto a la técnica que utilizamos para el estudio molecular. Interesante desde el punto de vista terapéutico, este estudio que es el DART Study, el SWOG 1609, un estudio basket que analizó la combinación de tratamiento anti-PD1 y anti-CTLA4 en tumores neuroendocrinos, observándose un 44% de respuesta objetiva en los tumores de alto grado, 0% de respuesta en los de bajo o grado intermedio, lo cual también lo hace digamos, a futuro, una posible opción terapéutica en aquellos casos con inestabilidad microsatelital reportados de acuerdo a este basket trial en los neuroendocrinos de alto grado, independientemente de la localización del tumor primario. Y en cuanto a las guías de tratamiento, en este escenario, solamente para resaltar las guías del consenso del Grupo Europeo, una de las primeras guías que aparecieron donde participa también la doctora Marianne Pavel y gran parte del Grupo Europeo, se estableció un primer abordaje, fíjense, en aquellos pacientes con enfermedad resecable, localmente avanzada o metástasis a distancia. La cirugía tiene un rol en aquellos pacientes con enfermedad resecable, la quimioterapia o quimiorradioterapia, como decíamos, de acuerdo a la localización, por ejemplo, unión esófago-gástrica, por ejemplo, en los tumores de origen distal a nivel recto y colon, la terapia locorregional y los esquemas de quimioterapia en base a la localización, platinotopósito como parte del estándar, pero tener en cuenta que hay otras opciones y aquí es donde debemos diferenciar los tumores neuroendocrinos G3 de los carcinomas neuroendocrinos. El grupo de Latinoamérica, liderado por la doctora Paola Montenegro, está llevando a cabo un análisis de tipo retrospectivo, donde estamos tratando de analizar también cuál es la evidencia del tratamiento adyuvante en aquellos pacientes con tumores de alto grado. Esperamos tener datos en un futuro no muy lejano en este escenario. Las recomendaciones locales en base a el consenso intersociedades en el grupo de la Argentina, diferenciamos los dos subtipos de G3, los pancreáticos versus otras localizaciones, y establecemos algunos criterios no muy diferentes a lo que sabemos por guías internacionales, en base a los esquemas de tratamiento con platino topósido y otras variantes en aquellos pacientes con tumores de tipo G3. Ya para finalizar, este es un trabajo muy reciente, publicado por la doctora Marianne Pavel y un grupo de expertos en el tema que me parece muy atinado, porque tiene un algoritmo que creo que es bastante práctico. Fíjense, NET-G3, donde aparecen esquemas de quimioterapia diferentes a platino topósido o terapia target, siempre y cuando tengamos en cuenta el tumor de origen primario a nivel pancreático. Ante la progresión, evalúan la expresión de receptores de somatostatina para poder identificar opciones terapéuticas. Los carcinomas con un Ki67 menor al 55%, esquemas de quimioterapia donde el platino topósido puede ser una alternativa, no la única, y ante la progresión, opción según la expresión o no de receptores somatostatina. En aquellos pacientes con un Ki67 mayor al 55%, lamentablemente, digamos, la única alternativa que tenemos hoy en día es en base al esquema clásico de platino topósido y las segundas líneas que tienen realmente muy mala respuesta en este escenario. Ya para finalizar, y como conclusiones de la presente charla, este subgrupo de pacientes con neoplasias G3 implica ambos escenarios, los carcinomas neuroendocrinos y los tumores bien diferenciados de tipo G3, aunque es un grupo heterogéneo que debemos identificar claramente. Aquellos tumores de alto grado son separados, me parece, de acuerdo con esta publicación de GATT y recomendaciones internacionales en estos tres subgrupos para el abordaje terapéutico, porque hay algún subgrupo como algunos carcinomas donde podremos tener probablemente alguna mutación accionable. El esquema de platino topósido sigue siendo parte del estándar, pero recordar que hay localizaciones como colorectal donde las respuestas son inferiores a lo establecido para otros subtipos, y en este caso usamos tratamientos similares a esquemas de adenocarcinoma colorectal avanzado, esquemas de triplete o combinaciones como FOLFOX o FOLFIRI. En el grupo de pacientes con inestabilidad microsatelital, hasta un 4 o 5% reportado dentro de los tumores G3 y de los carcinomas neuroendocrinos, puede tener respuesta, de acuerdo a este estudio Basket que les mostraba, en base a un posible rol de la inmunoterapia en este escenario. Claramente es una necesidad no cubierta buscar opciones de tratamiento en los pacientes con carcinomas neuroendocrinos, por lo que comentábamos previamente. Y con esto simplemente, y agradeciendo al SLAGO, dejamos un aviso del grupo en Argentina, el grupo de trabajo, tanto del sistema público como privado y el Hospital Udondo, donde se efectúan también ateneos mensuales solamente de esta patología con participación de distintos grupos en nuestro país. Y con esto los dejo. Muchísimas gracias. En este momento de hacer preguntas y algunos comentarios a las expositoras, a la doctora Pavel, a la doctora Riechelmann. Si quieren, podemos empezar con una pregunta. En base a los estudios que conocemos de estadificación, ¿en qué casos utilizan ambos estudios, fluorodeoxiglucosa, PET con galio 68, digamos, son solamente en los NET G3 o en su experiencia, Marianne, ¿en qué caso utilizarías ambos estudios para estratificar los pacientes? You're mute, Marianne.
Sorry, can you translate the question?
Ahora se está,
Sorry, no problem.
Okay, la doctora está pidiendo que le traduzcan la pregunta porque aparentemente no se conectó al canal inglés. Él está repitiendo la pregunta para estratificar entonces ¿Utiliza FDG 18 o Gallium 68? ¿Cuál es lo que ella sugiere para estratificar los tumores? Muchas gracias. Es una pregunta muy importante. Creo que hay una importancia en aquellos tumores de alta proliferación pancreático y tal vez también pulmón. Una alta tasa de proliferación también está asociada a alta proliferación y malignidad y puede haber heterogeneidad. Entonces, no solo se relaciona al NET3, también puede ocurrir en aquellos tumores G2. Por ejemplo, no es poco frecuente en los NET pancreáticos el tener un G2, tener más de 10% de KI 67, y se puede observar heterogeneidad y eso puede ser útil para la selección del PRRT. Antes no hacíamos FDG PET porque decíamos que no lo necesitábamos y realmente no nos ayudaba, pero hemos aprendido en el tiempo, a lo largo de muchos años, que podría ayudar a seleccionar a los candidatos adecuados para tratarlos con PRRT. Si uno no va lesión por lesión, la resonancia ha sido la imagen convencional que hemos utilizado y la búsqueda de expresión de receptores somatostatina. Tal vez hay áreas de más alta proliferación donde hay clones distintos en los cuales el tumor crece rápidamente. Y entonces algunos pacientes responden muy bien después de PRRT en términos de reducción de tamaño de tumor. Para detectar la heterogeneidad, particularmente en los tumores neuroendocrinos de páncreas y pulmón, es algo muy importante. Si yo considero a un paciente someterlo para trasplante hepático, lo cual es muy raro, un paciente joven que no tiene un KI 67 muy elevado, yo sin duda me gustaría ver si hay enfermedad metastásica. También me gustaría discutir, estoy traduciendo, si en general y el año pasado
Also at INETS we had the debate, is the FDG really needed
se
in all
ha
patients?
establecido el debate de si realmente se necesita en todos los pacientes. Y en los G1 obviamente que no, porque la mayoría son negativos. Y también en no todos los G2. Pero también este estudio le puede dar con FDG, darle un establecimiento pronóstico. Si es que hay una mayor homogeneidad, le podría dar más información en términos de un peor pronóstico. Realmente es un examen muy costoso que se deja para una población de pacientes muy seleccionado. Pero es muy importante validar esta herramienta imagenológico en cada institución. Pero en la rutina clínica sin duda lo utilizaría para las indicaciones que acabo de mencionar.
Okay, perfect. Thank
Muy
you.
bien, perfecto.
Your experience,
Muchas gracias. Su experiencia, Rachel, para el FDGP, hay 2 estudios que se están realizando en Brasil. Sí, está disponible, pero no ampliamente disponible. Algunas empresas de seguro primario no nos cubren, no está disponible en el sistema público. Tratamos de hacer un raciocinio lógico, como lo dijo Marianne, si lo tenemos disponible para todos, sería muy fácil la decisión, ¿no? ¿Qué es lo que tiendo a hacer yo? Solicito aquellos NET bien diferenciados utilizo el Gallium 68, pero para los otros tengo de utilizar el test cuando estoy haciendo la planificación con el lutecio 177, porque lo dijo Marianne, permite estratificar a aquellos que se van a beneficiar de la terapia con PRRT. Para tener también la información pronóstica es útil, pero si tengo un escenario de recursos limitados, no lo solicito.
Okay, thank you.
Muy bien, gracias.
Yeah, yeah.
Cuando voy a planificar para lutecio, lo dejo para eso, para esas circunstancias. O si hay un PNET en el hígado resecable y estoy pensando en una resección, podría ser una buena
A
elección.
question for you.
Una pregunta para usted, Rachel.
We see your
Cada vez que vemos sus datos presentados en el estudio Reminet y los datos del Clarinet 40, ¿cree usted que estamos listos para un cambio de práctica actualmente?
we need to
¿O
see in long term
necesitamos ver los resultados a largo plazo de estos estudios antes de tomar un cambio de decisión terapéutica? Creo que el estudio Reminet es muy interesante, aborda esa pregunta clínica que es muy importante. No creo que vamos a tener un fase 3 respondiendo a la misma pregunta. Es un estudio con un pequeño número de pacientes y esto es el NEPE.
Have the studies with a small number of patients. I think for patients who have a large volume of disease and who have very good response to first-line chemotherapy, I think I'm more inclined to offer it. So just an example, I saw a patient this week. She's 23 years old with a large bulky liver metastatic disease from a neuroendocrine tumor of the pancreas, G2, 15%. She had a very good response with first-line Captem, but now she has reached a plateau of response, now only stable disease. So I think that's, and she's experienced some toxicity from Captem after 10 months. So I think that's the perfect case, for example, to try to give something that will control the progression of the disease. And the PFS of 19 months in the median is really impressive. So I'm more inclined to do it, not for everyone, of course. For the Clarinet 40, I tend to dose increase the somatostatin analog, either lanreotide or octreotide, when patients have radiological stable disease, but clinical progression of hormone-related syndromes, mostly carcinoid syndrome, or radiological progression, but very minor, or something that we see that just small increase in the volume of metastatic disease, and we want to preserve patients' quality of life with a more gentle strategy. But if I have a patient with clearly radiological progression after the first-line somatostatin analog, then I move treatment strategy. I do not insist on the same agent, just increasing the dose. But I would like to hear Marianne. And you have to answer questions too, Dr. O'Connor.
Sorry, first, ladies first, Marianne, and after I give my opinion about this.
Okay.
Marianne?
Yes. Thank you. I think I'm very much in agreement with Rachel about the maintenance therapy of SSA. It's a small study, but it was an IIT, and we will not move to a phase 3. However, I would always continue SSA in functioning tumors. This is a minority, 10 to 30%, because all treatments, PRRT or chemo, do not really fully resolve the symptoms. So they may need to go on SSA always. Then if I need to shorten the chemo exposure, 10 months is even long. Some even make it for 6 months. So then I would also consider to go on a maintenance therapy if I need to shorten the exposure of chemotherapy. And I would also do it in high volume disease, because I do not want to wait for another progression, but prevent progression. Particularly if I used chemo upfront, then I could consider a maintenance therapy. But we did not prove that. The same is true for PRRT. With the NETAL-1 study, it was settled as a maintenance therapy, but we don't really have the data to support it. Some patients really may have durable response. So after PRRT, I only offer SSA as a maintenance therapy in functioning tumors or those with a very high tumor volume. It's also a tremendous cost. It's in Western countries, it's 3,000 euro per month. It's a tremendous cost for the healthcare system. It's not that we don't get that covered, but I think without having these data, it's very hard to justify that. I have some patients being on SSA for decades, for 20 years. And I really need to challenge, did they really need it? So there may be subsets that are naturally rather benign and slowly growing. And so we need to pre-select those at a higher risk. And we know that tumor volume is very important for overall survival. That had been shown by the PROMET study. Irrespective of the treatment, if they had been on placebo or octreotide, those with less than 10% tumor volume had an excellent long-term prognosis. So if you really have less than 10% tumor volume, you can even consider watch and wait, what is another question than maintenance therapy. But so I agree with the tumor volume and the length of exposure to chemo. For the high dose SSA, I also think these are the indolent patients where these are also young patients where I expect they may live another 20 to 30 years. So we don't know which risk they have to develop long-term sequelae. So what is threatening to me is a bone marrow damage. It's acute leukemia or myelodysplastic syndrome. It's between 3 and 5% for PRRT. So I would consider in some young patients with low tumor volume rather to go for high dose SSA instead of going to second line PRRT. Otherwise, in Midgut, PRRT is very well established as a second line. We recommend it not only in the ESMO guidelines, but it will probably be the recommendation in the updated ENETS guidelines too. And so it's also very convenient for the patient not to have an ongoing treatment, having just 3 to 4 cycles PRRT, and then you are off a treatment. That's very convenient for the patient. But high dose SSA is really for long-term sequelae the preferred choice in young patients, and I would consider it in very low progression patients. This means that I don't even perceive it if I stage the patient in 3 or 6 months. I would always say they are stable. If I look back for 2 to 3 years, then I perceive, oh, they are progressive. Sometimes it happens to me if you look at the tumor board, then I say, oh, let's look back 1 year, 2 years, 3 years, and then I see the lesion was growing from 1 to nearly 3 centimeters. And I didn't perceive that with staging them every 3 to 6 months. So, but these are the candidates being progressive indolent disease in 2 to 3 years. This was also the clientele we had in the Clarinet Forte. And I would say in the pancreatic, there are not so many that are a good fit for high dose SSA, and Rachel showed us the data. It's maybe 25% who have a durable benefit. And we need to identify those. We still need some more biomarkers. It's not only somatostatin receptor expression, it's probably those with low grade. So less than 5% KR67 in the pancreatic, or definitely less than 10% where we would consider high dose SSA also in the pancreatic setting.
Yeah, I fully agree. I think that they're selected patients. And the good news is that we have very good data from the clinical trial. So this is the pros and cons of the somatostatin analog, because it's not chemotherapy. So the maintenance treatment, I know the cost because it's not, it's an issue, the financial toxicity, more even in our countries, in LATAM, and also in different countries worldwide. But I think that it's good news for these 2 trials, not for all patients, but yes, for some selected patients, as you are mentioned, probably some patient good candidate for this strategy. So probably in order to the time, I would like to ask the last and quick question about the PRRT, Marianne. What's the next? PRRT plus chemo and NET-G3, for example, PRRT plus immunotherapy. What is those thoughts about the next for our vedette in the NET field, the PRRT? What do you think?
Yeah, a very important question. I must say, there's a control NET study from Australia showing a higher tumor shrinkage by combining temozolomide capecitabine with PRRT. However, the toxicity was so high in the interim analysis that I don't think that is a concept that we will follow widely. If you would, in exceptional patients with very high tumor burden, but then you also fear liver damage by combining these drugs, for me, that's too risky. I'm more in favor of sequencing therapies, one after the other, and reduce toxicity. So I would rather think that the combination of PRRT with immunotherapy, although we don't have any data, is very promising. If you can enhance the PRRT damage by using a combination. However, it's too early to judge that. If you ask nuclear medicine physicians from Switzerland, for example, they have a very long-standing experience, they would favor somatostatin receptor antagonist. I showed you one of these studies from Diane Reedy, that's a monotherapy, not a combination. I would say the alpha emitters are so striking for me. If this holds true, that they are really so safe, that is better than any combination probably. If the response rate is really 60 to 80%, and there is no bone marrow damage as we have seen with somatostatin receptor antagonists or combination of PRRT with plus chemo, that would be a very interesting concept. However, we need to see, if you look at radiation damage at the liver, if you use SEERT and so on, patients may develop liver cirrhosis. We don't have the full picture. It's too early to judge what will be the side effects of the radiation damage. So if I would need to make a choice now, my preferred choice would probably be the PRRT plus the immunotherapy, or the immunotherapy plus a TKI. Because these data with bevacizumab and nivolumab are the most promising in the well-differentiated net with respect to the response rate and overall disease control rate after a year. This was nearly 70% in pancreatic net. That was the best that we have seen. That was a study from Halperin from Texas. So this TKI plus checkpoint inhibitor and PRRT plus nivolumab. Also, we use sometimes SEERT and immunotherapy and have very good response in very individual patients, even a high-grade neck. I had, for example, a patient with a rectal neck, high-grade small cell, 80% Ki67. He failed to 4 lines of chemotherapy, has really undergone standard first, second, third line. We also use radiation therapy to control lymph nodes. And they had a very enlarged liver and high tumor volume in the liver. So we did sequential SEERT along with double checkpoint inhibitors. He had a dramatic tumor shrinkage, and he is now disease controlled for more than 1.5 years after 4 failures to chemotherapy. So I believe the combination of irradiation and checkpoint inhibitors is a good approach, either local regional approach, and we need to see how this will translate into activity with the PRRT.
I think that it's time. I would like to thank Marianne and Raquel, the very good leader from worldwide in this field. So it was a great pleasure taking the opportunity to give your thoughts about the future of this field. So I would like to thank, and I would like to invite for the next session in the SLAGO 2021. Thank you very much.
Thank you so much.
Thank
Lovely
you.
to see you. Have a successful
Thank you.
conference. Looking forward to
Have a
meet
great
you
weekend.
soon. Bye-bye.
Thank
Bye-bye.
you.